Now we're going to have a panel discussion where everyone can ask questions. And for those of you on Zoom as well, you can ask questions. And we encourage you to ask any questions. And they'll be read out here for the doctors to respond to. You want to come up on stage here? Ask.
I understand that after double lung transplant, they wipe out your immune system in order to not attack your new lungs. So when I take new vaccines, does it create a new immune system, or does it affect differently, or how does that work?
So that is an excellent question. So we do give 3 drugs that suppress the immune system. We don't completely wipe it out. It's a very fine balance, though, and it certainly affects the ability of the body to respond to a vaccine and mount antibodies to it. So we do know that when we give vaccines to people who have had a transplant, often when they do blood testing afterwards, we cannot detect the antibodies circulating. However, there are studies indicating that there is some protective benefit from the vaccines. It's not equivalent to people who are not on those immunosuppressive medications. So,
are you optimistic that we might eventually see a drug that doesn't just slow the scarring, but actually reduces it?
It's a tough question. So if I look ahead to where I think things are going to be a decade from now, I think we will probably be doing 2 things quite a bit differently than we are right now. One is that we will be using combinations of drugs much more than we are right now, and hopefully different drugs that are better tolerated such that we can kind of add them to one another. So that combination therapy is one thing. Second thing is that I think we will be applying more so the precision medicine, which is a bit of a buzzword, but basically means targeting drug to a specific biology, rather than a general diagnosis. By doing those 2 things, I think what we're doing now, so the drugs that are out there, the antifibrotic drugs in particular, they slow progression by about 50%. So you're still on average progressing. Instead of dropping by maybe 8% per year, you're dropping 4% per year. If we start layering on multiple medications, we're going to get closer and closer to that stability. The problem with the human lung is that it doesn't really regenerate. And taking away that scar tissue is I think a very, very different biological endeavor than what the current drugs are trying to do. So nobody is even really trying to study medications that might do that. And I would worry what those medications would do to the rest of your body if you're tearing apart the collagen that is making up the scar tissue. So I worry that you give a medication like that to somebody and they're just going to kind of fall apart. Because we need collagen and some kind of scarring like that in our body just to stay together. The one thing that people have tried is stem cell treatments, and that is very, very experimental at this point. That was the one study of 9 patients where 2 out of the 9 died in the few months after that treatment. That's a pretty intense and very experimental treatment. That's the one treatment out there that maybe holds promise for kind of rebuilding some of your lung in a sense. But that's so experimental that I hesitate to even bring it up right now. So I think it's a very, very long way away before we would be talking about reversing scarring.
But I get asked in clinic a lot, if I have fibrosis in the bottom of my lung, why can't I just have the lobe removed?
So good question. And maybe Dr. Wilson can add to this as well. But so if you have scarring in the bottom of your lung, there are very many ideas going through my mind right now as to why that's a bad idea. First of all, it's a big surgery to have some lung resected. There aren't that many surgeries that are bigger than having a whole whack of lung removed. So that's one issue. Second issue is that if you were to do that in somebody with pulmonary fibrosis, you're taking away not just some lung that's scarred, but some of that lung would actually still be functional. So you can't just take out the scarred area. You'd be taking out area that's actually functioning and contributing to your lung function. Second, you're not taking away the underlying kind of predisposition to future scar tissue formation. So you're still probably going to have some progression in the future. And that you might actually be making that progression worse by changing some of the pressure dynamics in your lung. You're going to be creating stretch. You're going to be creating stress during the time of surgery. And that actually is not something that you really want to be doing to people who have scarring. And you wouldn't want to do that to the remaining normal lung or healthier lung. So those would be a few things that quickly come to my mind as to why that's just not a good idea. I don't know if Jen has anything to add.
Yeah, the only thing that I would add, agree completely with Dr. Ryerson, is that any surgery, when you're thinking about lung transplant, will complicate transplant down the road. Yeah.
Question, and yes, that comes up more frequently than you can imagine. Yes.
After that question, we do have some questions online as well.
Okay, we'll do this one here and then online, and also Dr. Gooby is available for questions.
My name is Ranjit. I've got the IPF with the RA. First, I was diagnosed for RA, rheumatoid arthritis. Then I was IPF with the scars. So progression was very, very high, I can say. So then about 7-8 months back, I was given this OFEV medicine. It has given me some relief.
Sorry,
But-
which medication? Which
O-
medication?
OFEV.
Okay.
So that has given me some respect. But I don't know how long I can do. So I'm continuously going on the exercises and all those things and walking as well as other exercises. I'm also registered with the Lung Foundation for that rehabilitation program in the McGill University. So I also went through their program in the Victoria University for this pain and all these things. So I'm feeling good now, but I don't know how long we can go ahead. Thank you.
Yeah, I don't know if I have an answer to that. I would sympathize that it's a tricky thing to go through all the different medications, and the tolerability of those is often a challenge, and we're sometimes forced to abandon a treatment due to side effects or to progression and try alternative strategies. So I think it depends on a case-by-case situation as to what we would do in that situation. So. So my 2 cents, and I don't know if Jill is able to speak up as well, but my 2 cents is that we are never, almost never 100% sure about anything in interstitial lung disease. I would say a CT scan and the appropriate clinical context is probably never more than 98 or 99% confident about a given diagnosis. So there's always a little bit of uncertainty. The question is what type of uncertainty or what level of uncertainty would prompt us to change what we're going to do for you. So if we're 1% uncertain about that diagnosis, 99% confidence about that diagnosis, that's not enough for us to do things like a lung biopsy that does carry some potential side effects. So we often accept a little bit of uncertainty in the diagnosis, and that's just part of what we have to do. The other important point that I would make is that even if we are uncertain about the diagnosis, we are usually much more certain about the appropriate treatment. So if you were given a diagnosis of IPF based on the CT scan by somebody who knows what they're doing, it might be that you end up having evolution of things that lead us to a different diagnosis. So let's say you're given a diagnosis of IPF and 2 years later you get rheumatoid arthritis, and we say, well, you know what, all the way along you had rheumatoid arthritis as a cause of your lung disease. That might be true, but the treatment would probably still be the same treatment in the end. So in some respects, there's not much harm to be done by that mislabeling. So again, to summarize, I would say that we are almost never 100% confident, but the impact of that lack of confidence is usually not very significant.
Okay, so we have one other question. Is there a possibility to how long this put after 7 years of age?
That is a very hot topic of debate at national and international levels, and in our program as well. We do know from sort of international data that over the age of 65, patients do not do as well post-transplant. So age is a factor in, even if everything else is equivalent, age does carry an adverse prognosis. Our program does have a limit at the moment of 70 because of that data. We recognize it's imperfect data, and we recognize that sometimes there may be people who we would consider transplant at an older age. So there are some programs nationally and internationally that have pushed that envelope, sometimes successfully and sometimes not. So it's a gray zone. Well, everything depends on the individual for transplant. And everybody, I have yet to meet someone to tell me, if they're in their 70s, they all feel they're a good 70. And we don't have a good measuring stick for age and what that means for the reserve of the body.
Right.
Yeah.
What if we were in like super good shape physically and mentally? And
yeah, and we've, every program, there's always an outlier. It's difficult to measure that. Yeah.
Hang on. Dr. Gooby Dr. Gooby can hear you, but can't hear the question from the floor, so we have to use the mic for her to hear.
Dr. Ryerson, you mentioned that a lot of the diagnosis you might be 98%, 99% sure what it is. So like when we have the transplant, is there any pathology done post to confirm what it was?
Yeah, we try to do that. The reality is that by the time somebody comes to transplant, their lungs are so scarred that it often just looks like end-stage scarring. And there's a bit of a convergence no matter what the initial inciting cause was. It all ends up going to this mess of scar tissue. And so when we look at that under a microscope, we sometimes can see something that's pretty clear, but we're often left with, this is just end-stage scarring, and not able to distinguish.
Do you do autopsies on the lungs that you take out?
So those autopsy would be if the person was dead. We look at the explant. So we would look at the lungs that have been taken out under a microscope. So the pathologists do that for all of the lungs that are taken out after transplant.
Back to the patient.
Yeah, absolutely. That's part of the record. It often takes about 6 weeks to get that report out, but we're more than happy to share that information. And as Dr. Ryerson said, it's unusual that we get a surprising change in diagnosis related to the fibrosis, but we do sometimes pick up other concerning diagnoses. We do occasionally find lung cancer in the explant lungs. Sometimes we find infections in the explant lungs. So it's a valuable source of information. But yes, just ask. Ask away.
Has the research showed that it's genetic?
Jill, are you online? Are you able to speak and can we hear you?
You can hear us and see us, but you can't speak back.
Okay. Well, Jill will, Jill is much smarter than me at almost everything, but especially for this question. So there are a lot of studies looking at the genetics of pulmonary fibrosis and a lot of studies looking at the kind of the environmental precipitants of pulmonary fibrosis. And the simplest way that I would describe this is that we are all a combination of our genetics and our environment. There's not really anything else if you put it into those two buckets. And depending on which study you read, the risk of pulmonary fibrosis on average, if you look at everybody, probably about half of the risk comes from our genes and half of it comes from our environment. That's going to vary quite a bit depending on which article you read and which subtype of pulmonary fibrosis you're talking about, but around 50-50 kind of genetics versus environment. It's often, though, that it's not just one or the other. It's often that you have multiple kind of hits, and you have a genetically predisposed person who has an environmental trigger, or maybe it's not just one genetic kind of thing, but a few of these kinds of things, and then a few of these exposures over your life, and then the perfect storm arises and you end up having a diagnosis.
So I totally agree with that, Chris. The other thing I would say, there was a really great study that came out within the last year looking at the onset of idiopathic pulmonary fibrosis, and they were trying to get at this exact question, looking at, history of environmental exposures, but also someone's genetics and how do those two factors interact? And they found by developing a kind of genetic risk score for patients that people who were at kind of a moderate genetic risk score, so they had a few genes that maybe slightly increase their risk of developing pulmonary fibrosis, if they combined that with a high level of air pollution exposure in their environment over time, that combination of factors substantially increase the risk of those people developing IPF in the future. So it just is an example of how that genes and environments do interact. The group that was very high genetic risk, they weren't as affected as much by the environmental aspects because their genetic risk was just so high that they were likely going to develop pulmonary fibrosis anyways. But if you're somewhere in that middle group where you don't have all of those genetic risk factors, it does seem like that in lived environment is a really critical aspect there too.
Dr. Gooby, is there any studies being done with the forest fire fighters that are immersed in smoke for months at a time?
Yeah, that's a really great question. And they're a very special occupational group that certainly, I think, as we're seeing the burden of wildfires that we're experiencing in North America, that there's been a lot more interest in terms of occupational health and safety and looking at the risks of development of various diseases in firefighters. There is known to be, unfortunately, significantly elevated risks of many cancers as well as cardiovascular disease. So there have been studies that have proven those linkages, but the association with the development of interstitial lung disease, I would certainly suspect that there would be an increased risk of that, but it's hard to say because they're less common than cancer or cardiovascular disease, so we don't get as high of numbers, but I think that would be something that hopefully we'll be able to look into more in the future.
We do have one question. Before I get to the back.
Yeah, so it sounds like just to paraphrase, it sounds like this is somebody who is saying that in the past they would get shorter breath with a certain level of activity, and now they can do some activities without getting that same shortness of breath. And I'd say that there are multiple potential reasons that sort of thing can happen. That could relate to just improved exercise ability, just secondary to making your legs stronger, your heart stronger. It might relate to medications that have helped improve the amount of inflammation in the lungs. Again, we don't really improve the amount of scarring, but we can improve the amount of inflammation in the lungs. It could relate to weight loss, or it could relate to a change in habits, change in how much exercise that person is doing. Or even just a change in how they perceive things. So there are a lot of different possible explanations for that.
So in order to get on the list, which means that you would be ready to receive a transplant at any time, you need to go through the referral process. So you need a respirologist to refer you to the transplant team. That process to get in takes a few months usually, unless it's a crisis situation. And then we would evaluate if the time was right, and if you seemed like an appropriate candidate for general reasons, then we would embark on the evaluation. And if that seemed like it was the right time and there were no reasons that transplant would be a bad idea, then if you were in agreement, you would go on the list at that time to wait for a transplant.
Says I've got an initial assessment appointment with the team at PGH in about a month. What can I expect?
Well, first you'll have a sort of a screening questionnaire and an initial contact with the nurse specialist on our transplant team. We have two of them, and they're divided by the alphabet. So they'll ask you a number of questions about your current state of health and background history. And also at that visit, you will have a meet with the physician, either virtually through telehealth or in person, depending on where you are and what your situation is. And that visit is an hour. And then you'll have a chance to ask questions. So it's always good to come with some questions and make sure that don't be afraid to ask your questions of both the nurse and the physician.
I have a last question for Dr. Gooby. Now that the wildfire season is getting longer, more frequent and severe and intense, are we expecting that we will be able to measure the long-term effects of wildfire smoke eventually?
Yes, that would certainly be our hope, is to be able to study the effect of wildfire smoke. It's something that, I hope in my next several years within my position at UBC, that's something that we can look into. We do have quite a bit of expertise in this area at the University of British Columbia. Chris Carlston, who's the head of our respiratory division here, has a lot of expertise on wildfire smoke, as do Dr. Sarah Henderson and Michael Brower at UBC in the School of Public Health. So, I'm hoping that we can build those collaborations and initiate these projects, because I do think that they're really important questions, and I think we're ripe to answer them in British Columbia, especially with the resources that have been established through UBC, but also through Dr. Ryerson in establishing CarePF, and the great research infrastructure that we have here. So really hoping to take that charge.
Okay, one last question from me. This is often asked by patients with lung diseases. They're asking, is wildfire smoke more toxic than wood smoke?
That is an extremely complicated question, and we don't have a great answer to that. I would say that any smoke exposure is going to have potential risks and harms, and so I would counsel my patients to avoid proximity to smoke exposure either in their homes or outside of the home in general if they can. What we do know is that smoke and particles in the atmosphere change over time as they spread through time and space. And so, you know, the smoke that you have from the wildfires, if you're right beside where a fire is occurring, that composition of those particles that you're breathing into your lungs is going to be quite a bit different than that smoke that you know, someone 400 kilometers away may experience a couple of days later once they're getting that blown in smoke from a different area. So there's a lot of complexity in kind of the atmospheric chemistry and how those things change over time, that it's hard to pinpoint kind of what the toxicity is, and also, I think that varies depending on what exactly is burning as well, because, you know, a more coniferous forest of pine trees might be different than a more deciduous forest that has a lot of cedar or birch trees. So, you know, there's different chemicals depending on different plants and biomass that are burning. So I really think it's a complex and variable question.
Well, thank you to Dr. Ryerson and Dr. Wilson. It's been fabulous having you here, and to Dr. Gooby for awakening us to everything that's going out in the outside nature with us. And I hope to see you all here next year, and especially to the patients. Thank you for coming and attending and being part of the whole forum. It's important to the doctors and the team that work with the patients that you are here, and the education that we can help to provide, because it's all part of your ongoing treatment and learning to help yourself too. Yes.
Is that available online?
All the presentations will be on, I think, through CPFF. Are they not, Ray? Yeah, last I heard from Sharon, that was that they probably aren't right now, but they will be.
My comment urge that is that because that was an interactive presentation where you're talking as a physician and I'm listening to you as a patient, and there's a lot of questions that I would want to ponder that I could bring back to you, and it may enhance the relationship.